Good morning, everyone. It's my pleasure to welcome you to day 2 of the 6th International Pediatric Hematology Conference. After an inspiring first day, we are excited to continue with a full day of scientific sessions featuring renowned experts from around the globe. Today's program will explore cutting-edge research, innovative therapies, and practical application to advances the care of children with hematologic disorder. This is a unique opportunity to connect, collaborate, and contribute to shaping the future of pediatric hematology. Thank you for your dedication and participation. Let's make today another impactful and inspiring day. Welcome, and let's get started. So our first speaker is Dr. Iman Al-Ansari. Dr. Iman Al-Ansari is a pediatric consultant and neonatologist with over 10 years of experience. She currently practices at Salmania Medical Complex and serves as a clinical lecturer at Arabian Gulf University. Dr. Al-Ansari graduated from Dubai Medical College for Girls and completed her pediatric training and Arab board residency at Salmania Medical Complex, Bahrain. She further specialized through a neonatal perinatal fellowship at King Faisal Specialist Hospital and Research Center, Saudi Arabia. Welcome, Dr. Iman. The stage is yours.
Thank you, Dr. Najat. I will try to share my screen.
Okay.
I hope it is clear for you. Huh?
The screen is okay. The voice is not there. Can you,
The voice?
the voice is, yes.
Now you can hear me well?
Yes, Iman, yes.
Okay. Good morning and good day to you all. I would like to thank the scientific and organizing committee for having me today. I will be presenting today anemia and the neonatal period from a neonatologist perspective. I have nothing to disclose. Anemia is defined as a reduced hemoglobin concentration or RBC mass below the reference range for the patient age. Neonatal anemia is defined by a hemoglobin or hematocrit value that is more than 2 standard deviation below the mean for age. Decision of whether a particular hemoglobin value is sufficiently low to meet the criteria for neonatal anemia must be based on the infant birth weight, postnatal age, and the size of a blood sampling. As capillary, again, I seems that, sorry for that, but you can see me again?
Yes, Iman, we do see you.
Okay.
Please
Okay.
continue.
Okay, so the site of a blood sampling is very important as capillary blood samples is different than arterial and venous blood samples. And it is important to note that capillary blood samples, usually the hemoglobin level performed from capillary samples are higher than those performed from venous or arterial samples because RBCs will sludge in the small flow capillaries and transudation of a plasma will occur. Anemia may provide an important indication of a specific underlying disease process in need of immediate attention. When recognized immediately after birth, diagnosis and treatment of anemia is a matter of urgency. Anemia can be also classified according to the average size of the RBC compared to the normal level based on the mean corpuscular volume into microcytic, normocytic, or macrocytic anemia. Also, abnormal RBC morphology, including RBC shape, size, color, inclusions, and arrangement, will provide clues to the etiology of the anemia. Anemia can be divided into three broad categories, either related to accelerated blood loss or accelerated destructions of the RBC or diminished production of the RBC. Also, it can be classified either to the based on the onset of the anemia, either to the early onset or late onset. Early onsets occur within the first few days after life. Either it could be related to antepartum hemorrhage or related to twin-to-twin transfusion syndrome, fetal-maternal hemorrhage, or hemolytic diseases of a newborn as isoimmunization, including Rh disease and ABO incompatibility, or subglial hemorrhage, and hemorrhagic diseases of a newborn, either related to vitamin K deficiency or thrombocytopenia. Pulmonary hemorrhage, IVH, and GI bleed can acutely cause a drop in hemoglobin level. Also, congenital infection as CMV infection. While late onset could be due to anemia of prematurity, hemoglobinopathies, hereditary spherocytosis, sepsis, or NEC. For anemia evaluations, taking detailed history, including family history and the mother obstetric history, is important. Is of critical importance to reach to the etiology of the anemia. Also, to do the full detailed physical examinations and prenatally the non-invasive Doppler assessment of the fetal middle cerebral artery peak velocity is strongly correlated with fetal anemia regardless of the cause. At delivery, the placenta should be examined for evidence of hemorrhage, pallor, and abnormally inserted blood vessels or presence of clots or retroplacental clots. Laboratory investigation can be tailored based on the history and the physical examinations, and it includes usually the CBC with RBC indices, reticulocyte count, peripheral smear, hemoglobin electrophoresis, liver function test, and blood group and RH with a COMB test. Keeping in mind that COMB test could be negative, but once it is negative, even it will not exclude the hemolytic diseases. And also, direct COMB test can be negative in cases of ABO incompatibility, as there is fewer A or B antigen over the RBCs, and it is also there is more distance between the antigenic areas over the RBCs. Also, don't forget the G6PD activity, Clearhole test, and serologic testing to include titers to identify infectious agents, either bacterial, viral, or fungal infections as a causes for anemia. At times, a definitive diagnosis can be made only with a repeat testing later in infancy, when the infant could be expected to have much higher percentage of adult type RBCs, or when the infant has recovered from acute hemolytic crisis. Laboratory phlebotomy blood loss, which is the blood removed for laboratory investigation, is a byproduct of intensive monitoring of today's critically ill infants. Evidence supporting laboratory blood loss is an important contributor to neonatal anemia. Estimate of phlebotomy blood loss among infants in a neonatal intensive care unit, usually during the first 6 weeks of life, will range from 11 to 22 ml per kg per week. Keeping in mind the hidden blood loss, which is the blood loss adherent to sampling syringe, gauze pads, feeding, tubing, usually it is inevitable, and accurate assessment of the volume of blood loss removed for laboratory testing is undetermined. Unreported data have estimated the laboratory blood loss by 10 to 30%. A reduction in blood loss for laboratory testing almost certainly would decrease the need for RBC transfusion among critically ill neonates. Recent improvements have led to the development of alternative approach, reducing the sample volume required by laboratory instrument, as the use of microtainers and the point of care testing, in which these devices are capable of performing laboratory measurements accurately and reliably on a smaller blood volume. In the first few days of life, in the full-term infant, they have an elevated hemoglobin concentrations in the range of 14 to 20 grams per deciliter. Because of physiological decrease of erythropoietin level, the hemoglobin concentration usually decrease to a level of 10 to 12 grams per deciliter, approximately at the age of 2 to 3 months before it begins to rise, which is well known as the physiologic anemia of infancy. In the preterm infant, this anemia is more significant. It's usually reached to 8 grams per deciliter in very low birth weight infant and 7 grams per deciliter in extremely low birth weight infant. Usually, this is a result of lower hemoglobin concentration at birth, frequent blood sampling, low total volume to blood sampling ratio, and increased risk of comorbidities within these preterms. Also, diminished capacity of the premature infant to increase erythropoietin level. Management of anemia usually will need the management of underlying cause, packed RBC transfusions, and importantly, prevention. Now I will elaborate more further on the RBC transfusions. The primary function of the RBC is to transport oxygen from pulmonary bed to other tissue. Anemia usually will diminish the oxygen carrying capacity and will compromise tissue oxygenation. Tissue oxygenation, it is a complex concept. It will involve hemoglobin concentration, the oxygen affinity of the hemoglobin in the patient RBC, blood viscosity, and cardiorespiratory status. The main indication for correcting anemia by RBC transfusions are to restore tissue oxygenation and to expand blood volume after blood loss. Neonatal transfusions are performed and it provides adult RBC instead of fetal RBCs and hemoglobin, which have superior oxygen transporting abilities. And now the question is, how low should we go before giving RBC transfusion? In another word, how low will allow the hemoglobin to drop before giving RBC transfusion, which is, what is your hemoglobin transfusion threshold? So physicians, they struggle to decide when to transfuse RBC to the newborn. The guidelines for RBC transfusion remain controversial because there are few randomized controlled studies that address appropriate neonatal transfusion triggers. Infants with significant cardiac or respiratory disease, they receive more aggressive RBC transfusion therapy. And the generally accepted targets are to maintain hemoglobin or to maintain hematocrit value around 40% for severe cardiopulmonary disease, 35% for moderate cardiopulmonary disease, and 25% for infant with a stable anemia. Studies were established to address an appropriate and optimal hemoglobin target for transfusions. There is the BELL study, TOP study, PENT, and ITNO trials. They are all large-scale studies comparing different transfusion strategies in extremely low birth weight infants. They investigate the impact of different hemoglobin transfusion threshold on the health and development of a preterm infant, and they address the high versus low transfusion threshold and liberal versus restrictive transfusion strategies based on level of respiratory support. For the BELS study, which is a randomized controlled trials, they compare two level of hematocrit threshold of RBC transfusions. So they randomized the infant to either to the liberal or restrictive transfusion group. And they found that in the infants in the liberal transfusion group, they receive more RBC transfusions. And infants in the restrictive transfusion group were more likely to have intraparenchymal brain hemorrhage or periventricular leukomalacia, and they have more frequent episodes of apnea, including both mild and severe episodes. And they concluded that the finding of more adverse neurologic events within the restrictive RBC transfusion group would suggest that the practice of restrictive transfusion is to be evaluated. While in Penton's study, in which they it is another randomized controlled trial in which they randomly assigned infants to the low or high hemoglobin transfusion threshold. And the primary outcome was a composite outcome of death before home discharge or survival with any of either retinopathy of prematurity, bronchopulmonary dysplasia, or brain injury on cranial ultrasounds. And they found that there is a fewer infants receive one or more transfusion in low threshold group, and the rate of primary outcome were 74% in the low threshold group and around 69% in the high threshold group, where there is no statistically significant difference between both groups and the secondary outcome. And they concluded that to maintain higher hemoglobin level usually it results in more infants receiving transfusions, but it confers little evidence of benefit to the newborns. And another study in top trial, which is transfusion of prematures, it is another multi-center randomized controlled trial in which they randomly assigned infants to higher or lower threshold hemoglobin level. The primary outcome was again a composite outcome of death or neurodevelopmental impairment at 22 to 26 months of age. And they found that the result of this study, which was comparable between both groups, with similar incidence of death and survival with a neurodevelopmental impairment among both groups. And they concluded that in extremely low birth weight infants, a higher hemoglobin threshold for red blood cells transfusion did not improve survival without neurodevelopmental impairment at 22 to 26 months of age. In another study, an ethno trial, in which they randomly assigned infant into liberal or restrictive RBC transfusion threshold, and they studied that primary outcome was death or disability measured at 24 months of corrected age. They found that death by 24 months of age occurred in around 8.3% in the restrictive group, while it occurred in 9% in the liberal group. So they concluded that liberal blood transfusion compared with a restrictive transfusion did not reduce the likelihood of death or disability at 24 months of age. Some studies also have shown an association between transfusions and necrotizing enterocolitis, but these observational data have been inconsistent, and this finding has not been supported by available data from randomized controlled trials. But in some studies, they found that necrotizing enterocolitis likely occurred with a neither hemoglobin level decreased to below 8 grams per deciliter before the transfusions. So necrotizing enterocolitis more occur in neonates receive blood transfusion with a very low hemoglobin level reaching below 8 grams per deciliter. Also, transfusion has been linked to retinopathy of prematurity, bronchopulmonary dysplasia, and intraventricular hemorrhage in some studies. In other studies, They suggested that the risk of hypoxemia and apnea of prematurity are increased among infants who do not receive blood transfusions, and they allow the hemoglobin to drop to a very low level before giving any blood transfusions, and those who adapt a low threshold of transfusions. And another question is, what is the standard of dosing guidelines for RBC transfusions in a neonate? There is limited evidence for the optimal volume of a blood transfusion in this age group. The dose usually calculated based on ml per kg, and the current guidelines from the American Association of Blood Bank and based on consensus recommendations, they recommend that around to be given 10 to 15 ml per kg of packed RBC and with a maximum of 20 ml per kg, and the transfusion to be completed with a maximum of 4 hours. Several studies suggest that transfusion volume of 20 ml per kg could be beneficial without the negative respiratory effect, reducing the need for frequent transfusions. Volume of more than 20 ml per kg could increase the risk of volume overload. Also, the component of the RBC transfusion. What about the age of RBC transfusion? Most they recommend fresh RBC stored for 7 or less days. And the age of RBC transfusion trial in a premature infant, which is a randomized controlled trial, they suggest that the use of fresh RBC compared to a different storage age did not improve outcome, but likely to reduce the complications. Also, another point is to minimize exposure to multiple donors. And the adoption of single donor, the use of multiple aliquot for neonatal transfusion made from one adult blood donations can decrease the donor exposure. There is another preventive strategies have been evaluated in the literature as delayed cord clamping, initial blood test from the cord blood, and reducing phlebotomy losses. All it is recommended from some based on clinical trials. While medication as erythropoietin and darbepoetin, still they are under investigation. And based on evidence, delayed cord clamping in term newborn, it is associated with a reduction in need of RBC transfusion and improve hemodynamic stabilities and decrease the risk of intraventricular hemorrhage and necrotizing enterocolitis. While erythropoietin and the use of recombinant human erythropoietin has been proposed to decrease neonatal transfusion burden. But systematic reviews and meta-analysis have failed to demonstrate a clear benefit. And routine administration of erythropoietin in preterm neonates to reduce the number of RBC transfusion is not yet recommended. Subsequent meta-analysis reveals increased risk of retinopathy of prematurity in neonates who receive early erythropoietin therapy. Although recent studies were encouraging and they showed improvement in outcome and neurodevelopmental impairment. And another point, iron supplementation is a well-known within the anemia. And recent studies suggest improved iron stores if it is initiated early. A supplementation with 2 to 3 milligrams per kg of iron by 2 weeks of age and once infant reach to full feed. It will help to reduce the severity of anemia. And here we concluded that to reach to our end, that neonatal anemia is a common finding in the neonatal period of different etiologies. Packed RBC transfusion is the mainstay of treatment, and considerable variability exists in practice in regard to management and transfusion threshold. And anemia prevention must be a key goal. So that brings me to the end of my presentation. Thank you for listening and joining us today. Thank you.
Thank you so much, Dr. Iman Al-Ansari, for the excellent presentation. And I don't see any questions, so we'll move to the next speaker. Our next speaker is Dr. Rana Al-Maghribi, is a consultant in pediatric infectious diseases and an assistant professor at Al Faisal University. She serves as president of the Saudi Pediatric Infectious Disease Society and direct the Pediatric Infectious Disease Fellowship Program in the Saudi Commission for Health Specialties, certified in antimicrobial stewardship by the MAD-ID, and she's also a member of the WSPID Antimicrobial Resistance Declaration Committee. Dr. Al-Maghribi practices at Prince Sultan Military Medical City in Riyadh. Welcome, Dr. Rana. Dr. Rana.
Good morning, Dr. Najat. Is my voice clear?
Yes, it is.
Good morning, everyone. Thank you for the organizing and the scientific committee for this kind invitation. I have a non-conflict of interest to disclose. We are, as a pediatrician or infectious disease physician or as a hematologist, a week will not pass without us seeing sickle cell disease with infection, any type of infection or fever. From this point, I will start my presentation through this agenda by defining the relationship between sickle cell disease and infection. Then we'll highlight the potential risk for the infection and why the sickle cell disease is more prone to infection. Finally, we will end by reviewing the global strategy to improve the outcome in such population. As you know, the sickle cell disease is the most serious form of inherited hemoglobin disease as autosomal recessive disease, and the first case was recognized by Dr. James in 1910. And the first case in Saudi Arabia was reported in Eastern Province by 1960, and it is really high prevalence of sickle cell disease internationally. It affects 1 in 2,500 births, and this is the slide, or this is the map showing the worldwide distribution of newborn with sickle cell anemia. Globally, it affects 300,000 new cases each year. In USA, 100,000 individuals, and for sure the prevalence in the Africa, it is more and more, and it is estimated 2 to 30%. And in 2015, by our colleague reported in Saudi Arabia, it estimated 61,000 patients with sickle cell disease. Sickle cell disease, they are prone and they have high frequency of infection, either bacteremia or other type of infection, and they carry significant morbidity and mortality. As we mentioned before, Africa, it is really carry high prevalence of sickle cell disease, and also not only that, they carry high mortality, around 75%. And when we are talking about the mortality, less than 5 years of age, they carry mortality more than 50. For the childhood mortality, the peaked between age 6 months and 3 years. The question here comes, what is the relationship between the sickle cell disease and the infection? You know that a lot of pathology and the factor in sickle cell disease can cause infection, like splenic dysfunction, hereditary influence, immune dysfunction, and others. All this factor can explain the interrelationship between the sickle cell disease and the infection, can cause the infection and also the infection in terms of effect and cause through the fever, the dehydration, the climate, the emerging of the antibiotic resistance can affect on the splenic dysfunction. So there is bidirectional relation between the sickle cell disease and infection. When we start, why the sickle are high prone to infection? A lot of pathology, a lot of potential risk and factors. We will go one by one. First of all, splenic dysfunction. With the repeated sickling within the spleen lead to compromise the splenic function in form of filtration of microorganism or clearance of the organism. Hereditary influence in form of polymorphism in various immune-related genes have been proposed as a factor of infection. Immune dysfunction, it is one of the most important factors which make the sickle cell disease more prone to dysfunction. Because what? Because they have many mechanisms in related to the immunity in form of neutrophil dysfunction, decreased humoral immunity, so no immunoglobulin, or impaired various directed immunity. All these factors can lead to infection in sickle cell disease. Not only that, opsonization. When the sickle cell disease, they have reduced the opsonin production, which is lead to decrease the ability to destroy the encapsulated organism or killing this organism. And I want to highlight here on the encapsulated organism, which is Streptococcus pneumonia, Neisseria meningitidis, and Haemophilus influenza as a gram-positive. We have another gram-negative considered as encapsulated organism, which is the Salmonella infection. There is another factor can prone the sickler to have an infection, which is nutritional dysfunction. One of the examples, zinc deficiency, which lead to lymphopenia and decrease AH response. So all this risk of infection. And there is another type of nutritional dysfunction or deficiency can cause infection in sickler. Mechanical factor. You know, the sickler, they are more prone to infarction, vaso-occlusive crisis. So secondary to sluggish circulation, leading to infarction in osteoarticular function, either bone or joint, which then act as an obvious for bacterial proliferation and growth. Finally, molecular mechanism of clinical manifestation in sickler. As you know, vaso-occlusive crisis, endothelial dysfunction, and hemolysis. Anemia per se, they participate in risk of infection in those population. So we talk about the risk factor and the potential risk of infection and the external or environmental determinant, either climate. You know, the infection is common in low socioeconomic classes or in poor population, so the infection is more. So what is the infection common in that group? Sickle cell disease, they prone to different type, many infection. When we are talking about bacteria, viral, and parasitic. When we start about bacteria, as we mentioned before, encapsulated organism, they are the commonest organism or pathogen cause infection in those population. Neisseria meningitidis, Streptococcus pneumonia, Haemophilus influenza. So what is the presentation? Either CNS infection or respiratory tract infection in form of pneumonia, complicated pneumonia, acute chest infection. Not only gram-positive, also gram-negative. It is one of the common bacteria can cause infection in sickle cell disease in form of E. coli, Klebsiella, and the manifestation usually urinary tract infection. So in pre-vaccination pathogen like strep pneumonia and other, bacteremia account 10 to 23% of febrile cases with sickler, and carry high mortality around 35 to 50% in infant. So the other bacterial infection or other side of infection in sickle cell disease, which is the osteoarticular infection, which is either osteomyelitis or septic arthritis. And the commonest organism for that, the gram-negative, which is the encapsulated organism, which is Salmonella. But again, the Staph aureus is still common pathogen for osteomyelitis and sickler. So the osteomyelitis is common, we agree about that, carry 0.5 to 16% in sickle cell disease, and also the UTI common in sickle cell disease carry 6 to 26% and can lead to septicemia. There is another bacteria, either Acinetobacter, another type of Staphylococcus, all can cause bacteremia and sickler, but the most common again and the major cause of the pneumonia, which is the streptococcal pneumonia, which is the trigger acute chest syndrome, which is the common manifestation of respiratory tract infection in 50 cases of sickle cell disease. What about viral? Sickler, they are prone to different type of viruses, include parvovirus, influenza, different EBV, CMV, a lot of virus. But what is the impact of these viruses in sickle cell disease? When we are talking about the influenza and rhinovirus, can cause acute chest syndrome, and also it will lead to a aplastic crisis as one of the crises in the sickler patient. Parvovirus 19 can cause also a aplastic crisis, and also another virus is important in consider in sickle cell disease, HIV, which increase the bacterial infection risk in those population. Dengue fever also can lead to risk of capillary leakage and hypovolemia, and more lead to more dehydration and vaso-occlusive crisis. What about the parasitic infection? As we know, parasitic malaria, it is on the top, which is the Plasmodium vivax, falciparum, and the other. Sickle cell disease, it is really face a higher mortality from malaria, especially when we are talking about the homogeneous type, but heterogeneous type of sickle cell disease is they have lower risk of malaria. And we have another type of GI parasitic infection, Ascaris, tracheus, all the type of parasitic infection can cause pneumonia and worse anemia, actually, and increase the need for transfusion in those type of patients. Schistosoma also is common in sickle cell disease and exacerbate the anemia. Also, they raise the risk in UTI in this population. TB, yes, it can happen in sickle cell disease, especially mycobacterial tuberculosis is common, especially when we are talking an endemic region. And as you know, the standard treatment is effective. So we know why sickle more liable for infection, and what is the environmental factor lead to more infection, what type of infection. And now we will go to the global strategy to improve the outcome. And this is our aim as a partner, infectious disease and sickle cell physician. We are really work together. So by Lancet Hematology Commission, they defining, and this is recent, nice paper actually, they defining the global strategy to improve the outcome of sickle cell disease through different crises, from vaso-occlusive crisis, aplastic crisis. But here, I will concentrate about the prevention measure or the treatment measure in acute clinical event in form of infection and specific for acute chest syndrome. So we are talking about the global strategy to improve the outcome. Usually we are talking about the prevention either by prophylaxis, antimicrobial, or vaccination. We consider the strep pneumonia, it is in the top of cause of invasive pneumococcal disease, and the incidence really high. It is about 6 cases per 100 patients per year, and it is carry high mortality, as we mentioned earlier, in children younger than 3 years. So there is an important role of antibiotic prophylaxis, and all of us carry this practice, and this is a standard actually. So what they found antibiotic prophylaxis have been lowering the rate of infection as a complication and mortality in sickle cell disease around 84%, which is a high percent with minimum side effect. So the most important thing, and maybe if Dr. Najat allow me, I will enter the stewardship here, because really the dosing, the duration of whatever antibiotic, it will minimize the resistance. And you remember the previous slide, the resistance, it is one of the important factors which is effect on sickle cell disease. So we have to know when we will stop the penicillin and what is the dose of prophylaxis. So usually we use the penicillin, which is the Ospen, and most of the literature actually they recommend to discontinue the penicillin at age of 5 years. But there is specific in the specific patient, if no history of invasive pneumococcal disease, if no had splenectomy, if they have adequate vaccination against especially pneumococcal disease, because the penicillin covered the pneumococcal strep pneumonia. So this is the indication when you want to discontinue the penicillin. However, I met a lot of expert people, and it depends on the institute. They said also they consider stopping if they make sure the compliance of the medication or from the family or the parent for this medication. But if not, they will change the plan. Actually, in the recent study in 2025, there is some article, they are talking about the recommendation in certain country like US, they stop it in the 5 years, and this is the standard protocol. However, UK, they continue with the antibiotic as a lifelong penicillin. And in some area in France, they stopped the antibiotic when the patient starting high school or secondary school around by age of 10 years. And some area, which is sub-Sahara area, they given or they recommend the penicillin according the availability and the affordability of penicillin, which means some sickler they didn't receive. So there is a different protocol, but actually the standard protocol of penicillin, it is the recommendation for the most of the study and discontinue at 5 years of age. So in case you don't have penicillin, in case of allergy, you have alternative, yes. We have erythromycin. It will cover the commonest organism of pneumonia or streptococcal pneumonia and sickler. So we have the second strategy, which is the vaccination, and alhamdulillah, it is available everywhere. We have before the heptavalent pneumococcal conjugated vaccine, which is the BCV7, which covers 7 serotypes of strep pneumonia and lead to 70% decline in invasive pneumococcal disease. When we go further, we found there's another vaccine available, which is BCV13, more serotype cover, has further reduced the incidence of the severe pneumococcal infection. And nowadays, more and more vaccination, BCV23, and now coming in the market, BCV20 and 15. So what is the protocol in using vaccination in sickle cell disease? BCV vaccine, usually there is a vaccine series, usually given in the first year of age, followed by the booster dose at the second year of age, and some countries recommend booster dose every 5 years. Another vaccine, it is very important for the encapsulated organism, which is meningococcal vaccine, either to cover the serotype ACWY or B, and now the vaccine for meningococcal B, it is available, and I think it is introduced in many countries in a lot of institutes. So there is a protocol for both vaccine, either as a serious vaccine initially, as a conjugated vaccine, and then we have a booster vaccine for the high-risk group. We have to recommend it after 2 to 3 years. In meningococcal B, again, there is 3 doses, 2 months apart. This is the serious vaccine of meningococcal B, followed by 1 vaccine booster at 2 years, and then every 3 years we give the other one. The third vaccine, it is very important in our patient, the sickler patient, which is the annual influenza vaccine. It is very important, and we recommend to consider in all our patients with make sure the compliance to the prophylaxis antibiotic and the vaccination. I will not forget in this SARS-CoV-19 era, COVID-19 carry high mortality and sickle cell disease. And in some article, actually, especially in Saudi Arabia by Dr. Shaheen and Dr. Faraidi, they mentioned the outcome there for 212 patients. They carry good outcome, but still there is high mortality of COVID worldwide reported. So we have to make sure the immunization and effective therapy of this type of infection for our patient. Salmonella, we consider it is one of the important organism, gram-negative, cause osteoarticular infection, and commonly we have to consider in any empirical therapy for sickle cell disease. There is upcoming vaccine. We have 2 vaccines, either oral live attenuating vaccine or inactivated vaccine, but not yet actually implemented, and they indicated for travel to endemic area with salmonella, and still we need further study to study the efficacy in a person with sickle cell disease. Not only vaccine, not only antibiotic prophylaxis, there is another of preventive measure to improve the outcome in infection in sickle cell disease, especially when we go to endemic area like for malaria, for dengue fever. We have to use the infection control measure in form of use of maximum mosquito protection, and also malaria like chemoprophylaxis. And there is a lot of talk about the long-term malaria chemoprophylaxis has been shown to lower incidence of crisis, hospitalization, and reduce mortality. However, all recommended further study, more study, to make sure the benefit of and the efficacy of the antibiotic and the weighing with the side effect of these medication. In the same recent article about the global strategy in 2025, they make very nice table according to the type common infection in sickle cell disease and the common prevention, either vaccination and what type of vaccine, what type of infection control measure, and the antibiotic prophylaxis. Not only that, also as we mentioned, there is another supporting measure to improve the outcome: nutritional support, hand hygiene, water and food decontamination, encourage the good, healthy food. All these factors can help to improve the outcome. There is a lot of visit for our patient in the ER, and this is documented in the literature. Around 40% visit in the ER by sickle cell disease. Either, I'm talking about pediatric, either by fever, either by pain, or both. So what is our rule to improve the outcome in such case? In the same paper, in the Lancet, they said you have to thoroughly evaluate your patient, especially if they have temperature greater than 38.5, should be investigated, full history, full investigation according to the site of infection, CBC, and X-ray if they have respiratory symptom. And don't forget, in such case, consider empirical antibiotic for the commonest organism. And also there is other consideration to relieve the pain, and you are the expert on that, non-steroidal and acetaminophen, high hydration, hydroxyurea, and this is, I think, your part, mechanical ventilation to support the respiratory if the patient needs supplement like zinc, C, D, vitamin, can improve the outcome in such cases. The other category, and I think need another lecture for that, which is the acute chest syndrome, which is defined as a lower respiratory tract infection, and the symptoms really need evaluation and the management, and most of them with the deep saturation need admission, need hospitalization. So chest X-ray, we need serial measurement of oxygen saturation, very important. As ID, when we are consulting in such case, we want to make sure we did the microbiological documentation for common organism, viral workup. It is very important. In the same time, make sure the supplementation with the oxygen to maintain the oxygen between 92 and 95. Don't forget, there is a lot of things can worse the acute syndrome. It is not infectious, like pulmonary embolism, fat embolism, fluid overload, hypoventilation, but in the same time, you will not ignore the infection, which is caused by the commonest organism, atypical pneumonia, chlamydia pneumonia, mycoplasma pneumonia, and strep pneumonia, staphylococcus, Haemophilus influenza, also documented as a cause of acute chest syndrome. For that reason, the first antibiotic you usually, as a treatment, third generation cephalosporin, the most common, and this is written in the literature, as intravenous plus oral macrolide as antibiotic, plus the bronchodilator can help relieve any reactive airway disease. From your side, blood transfusion you will consider in acute chest syndrome. For respiratory failure, we have to really support that by humidified oxygen to decrease the need of mechanical ventilation. Finally, there are several factors can lead to infection and sickle cell disease. You have to understand it for that, and you have to know what the commonest organism, immune deficiency, splenic dysfunction, emerging of antibiotic resistance, and there is big role of stewardship here. Consider systemic prophylaxis for penicillin, antimicrobial, anti-pneumococcal vaccine, and other preventable vaccine can reduce the risk of serious pneumococcal infection. Finally, I want to end my presentation to remind us as infectious disease, and really we are welcoming towards sickle cell disease next month in 2025, and the theme for that day, empowering community for effective self-advocacy. And as Saudi Infectious Disease Society, we are welcoming to collaborate with the International Hematology Society to celebrate this day. Thank you.
Thank you so much, Dr. Rana, for the excellent presentation. There are 3 questions for you. The first one is, aren't sickle cell disease patients have resistance to malaria infection compared to healthy individuals?
Okay. This is what we know. Yes, this is what we know before. Yeah, actually, when we dig in the literature, they are classified the sickle cell disease as a homogeneous sickle cell disease and heterogeneous. What they mention, sickle cell disease, the heterogeneous type, carry the protective against the malaria because they have splenic function. It is already there, so they clear the sickling erythrocyte. But the sickle cell disease, the homogeneous type, they have dysfunction of the spleen. So for that reason, they cannot clear the erythrocyte, sickled erythrocyte, and they are risky for more malaria. When we are talking about the protective measure for heterogeneous type.
Yes, I do agree. I mean, the sickle cell trait, they are the resistant to malaria, not the sickle cell disease patients. Okay, we move to the next question. Now availability of PCV 20. Is there a plan to replace the PCV 13? As some countries have already adopted that.
Yes, yes. يعني we have to admit streptococcal pneumonia vaccine in general, it is very important in our population. BCV 20, it is already approved by FDA, and in our country, Saudi Arabia, it is approved 20 and 15. For sure, they will put it in their mind, but I think we will wait from the NETAG committee to decide about that. Yes, it is one of the consideration.
Okay, and the another question is, what is the antibiotic prophylaxis plan of Bahrain? Now, in Bahrain, we give the penicillin prophylaxis is a must till the age of 5 years. After 5 years, if the child has no splenectomy, no recurrent infection, if the child and the mother, we give them the choice. If they are happy to continue the penicillin prophylaxis, we do continue indefinitely, or at least until the mother and the child not happy, means wanting to stop the penicillin prophylaxis. But before the 5 years, it's a must for everyone.